Hi everyone, and welcome back to the channel. If you're new here, this channel is where we break down complex medical topics and make them approachable, whether you're a healthcare professional, student, or just here to learn about your health. Today, we're doing a full deep dive into lumbar spinal stenosis, or LSS. This is one of the most common causes of lower back and leg symptoms in older adults, and one of the top reasons patients undergo spine surgery. So let's walk through everything, from what it is and how it develops, to how we diagnose and treat it. Before we begin, this video is produced by Dr. Rezaian, a specialist in arthritis and rheumatology, for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. Lumbar spinal stenosis, or LSS, refers to a narrowing of the spinal canal, lateral recess, or intervertebral foramen in the lumbar spine. This narrowing can compress the spinal cord and/or nerve roots, leading to characteristic symptoms like neurogenic claudication or radiculopathy. LSS can be classified based on both etiology and anatomic location. By etiology, congenital or developmental stenosis means the spinal canal is narrow from birth. It's often associated with conditions like achondroplasia or scoliosis. Acquired or degenerative stenosis is the most common type. It's caused by age-related changes, including intervertebral disc degeneration and bulging facet joint hypertrophy, thickening or calcification of the ligamentum flavum, and osteophyte or bone spur formation. Iatrogenic stenosis occurs after surgery, typically due to post-laminectomy fibrosis or instability from a prior procedure. Other causes include trauma, inflammatory arthritis like ankylosing spondylitis, tumors, or infections. By anatomic location, central canal stenosis refers to narrowing of the central spinal canal. Lateral recess stenosis means narrowing where the nerve root exits the thecal sac. Foraminal stenosis is narrowing of the intervertebral foramen. In LSS, the narrowing of the spinal canal leads to mechanical compression and ischemia of the cauda equina or lumbar nerve roots. Walking or extending the spine worsens symptoms by reducing the canal diameter. This happens due to buckling of the ligamentum flavum and facet joint pressure. Lumbar flexion, like bending forward, temporarily improves symptoms by increasing canal space. LSS primarily affects adults over 60 years old. It's one of the most common indications for spinal surgery in older individuals. There's a slight male predominance in those who undergo surgery. Classic symptoms include neurogenic claudication, pain, numbness or weakness in the buttocks, thighs, or calves triggered by walking or standing, and relieved by sitting or bending forward. This is usually bilateral, though it can be asymmetric. Radiculopathy, dermatomal pain or tingling due to nerve root compression, sometimes mimicking sciatica, chronic low back pain, mechanical in nature, and may wax and wane, gait impairment, and balance problems, especially in more advanced cases with lower extremity weakness. Rarely bowel or bladder dysfunction, a red flag for cauda equina syndrome, which is a medical emergency. On physical exam, the neurological exam can often be normal at rest. A classic sign is the shopping cart sign. Patients feel better when leaning forward, like when pushing a cart. There may be weakness, reduced reflexes, or sensory changes in affected nerve root distributions. In severe cases, gait may become wide-based or the patient may struggle with heel or toe walking. Before labeling someone with LSS, it's important to rule out peripheral vascular disease or vascular claudication, diabetic peripheral neuropathy, lumbar disc, herniation, cervical or thoracic myelopathy if the lesion is above L1 hip or knee osteoarthritis, normal pressure, hydrocephalus, and motor neuron diseases. Imaging is key. MRI of the lumbar spine is the gold standard. It shows canal narrowing, ligament hypertrophy, and nerve impingement. CT myelogram is great for those who can't undergo MRI and offers clearer detail of bony structures. X-rays might reveal degenerative changes, scoliosis, or slippage like spondylolisthesis. Electromyography or nerve conduction studies can help rule out peripheral neuropathies or confirm nerve root involvement. We always start with conservative treatment unless there's neurologic decline. Activity modification includes avoiding activities that worsen symptoms and walking with forward flexion when possible. Physical therapy focuses on core strengthening, stretching, and posture. Medications include NSAIDs, neuropathic pain agents like gabapentin or duloxetine, and epidural steroid injections for temporary relief. Assistive devices like walkers or lumbar support belts can provide added stability and comfort. When symptoms persist or there's neurologic worsening, surgery is the next step. Decompressive laminectomy, with or without spinal fusion, removes the lamina and ligamentum flavum to relieve pressure. This is the most common and most effective surgery for central stenosis. Foraminotomy targets nerve root compression in the foramen or lateral recess. Spinal fusion is reserved for those with spinal instability, like spondylolisthesis. Minimally invasive options, like interspinous process devices such as the X-stop, may help in selected cases. Most patients do well with non-surgical care. Surgery provides long-lasting relief in carefully selected individuals, but delayed surgery can mean poorer outcomes if nerve damage progresses. Potential complications include ongoing or progressive nerve damage, falls due to balance issues, and surgical risks like infection, spinal fluid leak, or adjacent segment disease. To recap, lumbar spinal stenosis is a mechanical narrowing of the lumbar canal, usually from age-related degeneration. The classic symptom is neurogenic claudication that improves with forward-bending MRI, is your best friend in making the diagnosis. Start with conservative care and reserve surgery for those who don't improve or worsen over time. Thanks so much for watching. If you found this helpful, don't forget to like, subscribe, and share it with others who might benefit. Have questions? Drop them in the comments below. Until next time, stay informed, stay healthy.